All right, guys, so we're going to talk about patient assessment. You have this full PowerPoint. I took a few things off of this just for the video version so it didn't get confusing. But you have the full PowerPoint at your disposal that I encourage you to look through for some of those details as well. But I just wanted to talk to you a little bit about it. Patient assessment, one of the most important things, if not the most important thing that you are going to learn in this class, or being an EMT or really a healthcare provider in general, whether you want to stay in EMT, if you want to be a paramedic, a nurse, a doctor, PA, whatever your plans are, you're going to be using patient assessments. You're going to be using it for every type of call, and we need to really build on this. So it's very important that we do it and that we're able to get it right, because if we can't find the problem, then knowing how to fix it really doesn't matter. Okay, so we're going to break this assessment process down into 5 parts, and then each of those is going to be broken down further into individual steps so that you can kind of see how everything should progress. So the 5 parts that we're going to talk about are scene size up, primary assessment, history taking, secondary assessment, and then the reassessment phase. And like I said, we're going to break each one of those down. So first is scene size up, and the very first thing we need to note is the scene safe? Okay, so your safety should be your number one priority if that means that you have to leave until the scene is safe, if it means you need additional resources. But remember, just because law enforcement is on scene does not make the scene safe. They don't have the ability to protect you and to control the environment and be able to see everything that's going on there. So remember, while that is one tool, you could still be in danger. All right, so your safety first, then the safety of your partner, then the patient, and then anybody else who's there on scene. Now, historically, you might hear people say scene safe PPE or scene safe BSI, so personal protective equipment or body substance isolation. But we want to add a second step in between those two, which is mechanism of injury versus nature of illness. If we don't determine the mechanism of injury versus the nature of illness, then we really don't know what type of PPE we should be wearing. Okay, so we need to add that middle step. Now, mechanism of injury obviously leads us to believe that the patient has been injured in some sort of way. Nature of illness is going to be more of a medical-related complaint. Now, the patient could potentially be suffering from both, so we don't want to get tunnel vision. With the PPE, again, we got to determine what type of PPE do we need. Is gloves at a minimum for every call that we go on to? But again, do we need airway protection? Do we need additional blood splatter protection? Do we need a face shield? Do we need goggles if we're managing the airway? Do we need turnout gear if this patient is trapped inside of a vehicle? So being very cautious about choosing our PPE. Then we need to know the number of patients, and that's going to help us to determine the need for additional resources. So the additional resources are going to be anybody who was not dispatched with you. So that could be additional units, it could be fire department, law enforcement, public safety, public works, whoever it is. If they were not dispatched with you and you're requesting them, then that's an additional resource. So you're going to want to request them as early as possible. And that's going to bring us down to primary assessment. Now, there are 6 parts to the primary assessment. Number 1 is the general impression of the patient. So what we want to do is, in those first few seconds of gaining access to the patient, we're going to look at them, and we're going to be able to tell a few pieces of key information. Their approximate age, sex, race, appearance, position, level of distress. Do they have signs of life? Do they not? So those are some key things that we're looking for as we approach. Once we're making contact with the patient, we're going to determine their level of consciousness, or LOC. All right, and you do that using the AVPU scale. Now, that's broken down in the main PowerPoint for you a little bit more, but remember that A stands for alert. So if the patient is alert and they're making eye contact with you, they would fall into that category. If you say, hey, are you okay? Or you call their name and they respond in some sort of way, then they're responsive to verbal stimuli, which would be V. If they don't, then you would inflict some type of painful stimuli like a sternum rub, a pinch of the earlobe, that type of thing. If you have a response to that, then they would be responsive to painful stimuli. And if not, then they would be deemed unresponsive. Now, at this point, if the patient is unresponsive, we want to check circulation, airway, breathing. You see that airway is listed as number 3. And so in a traditional patient, anybody else who's not unresponsive, we're going to want to go with A, B, C. But for the patient who is unresponsive, it should be CAB, meaning we're going to check a pulse first, then check the airway, then check the breathing, that type of thing. So just knowing the difference of when to use that, and that's further explained in that initial PowerPoint as well, like I said. Now, just because the patient is awake doesn't mean that they are oriented, all right? So that's where the A and O times 4 comes in. So if the patient is talking to you or awake, we want to ask some questions related to person, place, time, and event. Again, you can see that main PowerPoint for examples of those questions, but remembering there is a difference between being alert and being oriented. Now, like I said, if this patient is talking to you and you're going to go with ABC, then you're going to check the patient's airway. So is it open and is it patent? If they're talking to you, then yes, their airway is open and patent. You don't really need to look unless they're having trouble breathing and you suspect an allergic reaction or a foreign body obstruction, then you could take a look in there. But this is mainly for patients who are unresponsive or have an altered level of consciousness for us to see, is their airway open? And then is it patent? Again, patent being do they have the ability to keep it open? We also want to look at the patient's breathing. So we're going to look at the rate, the rhythm, and the quality of the breathing. If there's any trouble with that, rate, rhythm, or quality, then we're going to want to intervene. And generally that's going to be with a bag valve mask. We're going to provide ventilations for the patient. Now, if they're having some difficulty breathing and it's really severe, but their rate, rhythm, and quality is really okay, then we could go with supplemental oxygen. But usually when we're thinking about intervening for a life threat in the primary assessment, we're talking about the need for ventilations with a BVM. Okay, so good rule of thumb, if they're breathing less than 8 or greater than 28 times per minute. But we also want to make sure that the patient is tolerant of that. If I'm awake and talking to you and having a panic attack and breathing 28 times a minute, probably not going to be too tolerant of you putting that mask on my face. Now, once we make it down to circulation, like we said, if the patient's unresponsive, then we check this first, check the pulse first, then airway, then breathing, then come back to the last 2 parts of circulation. There are 3 parts. That's pulse, skin color, temperature, and condition, and then rapid scan for life-threatening bleeding. If we're checking the pulse, we're most likely going to be comparing the carotid and the radial pulse. Remember, if we do not have a carotid pulse, we need to start CPR. But it is possible for us to have an absent radial or absent peripheral pulse and still have a strong central pulse like at the femoral or the carotid site. We also are going to look here for skin color, temperature, and condition. That's going to tell us a lot about perfusion and how well the patient is doing. So warm, pink, and dry is normal, and any variation of that is not. And we'll talk more about that in the vital sign chapter. And then the rapid scan for life-threatening bleeding. So in the example video that I'm showing you guys that where I'm performing the patient assessment, you'll see how I'm doing that, placing my gloved hands behind the patient and pulling them out behind each body part so that I can see, is there any blood? I'm not dragging them down the body. And then the last part of the primary assessment is going to be the patient priority. And so here we're going to start determining, is this a situation where I need to load and go? The patient is critical. Or is this a situation where I can stay and play? I've got some opportunity here to stay and provide some treatment on scene. It's not a life threat. We don't really need to go anywhere super quickly. All right, so this few pieces of information should only take you a couple of minutes. We talked about some of them, and that's what's taking the longest. But when you're performing this should be done in maybe a minute, maybe 2 minutes between scene size up and primary assessment. So I'm going to stop here for this portion of the video, and I'll pick up in a part 2.